know my group. When they first got this stuff, they were like, "Oh my god!" But look at y'all. All right. How do you prevent infections? Do you change the tubing, primary tubing every 24 hours? True or false?
False.
You use a three-way stopcock?
False.
False. False. We're trying to prevent infection. You scrub the needleless connector with alcohol and then fan it dry?
False.
False. Do you use an alcohol cap or a needleless connector between the use if available? True or false?
True.
True. That's true. You're discharging a patient home with the PICC line. What are you going to teach them? You're going to teach them that they can get it wet?
False.
False.
Right.
Do you want to teach them that they need to use a occlusive transparent dressing and have it changed every 3 days? True or false?
False. Ain't it every week? Like every 7 days?
Well, now y'all need to go back and review that, because I believe it says something about the central line dressing and the PICC line dressings. There's a variance between when you change it based on whether it has a patch or not, or whether it has a gauze.
Oh, the gauze is 7 days. The gauze
is 7 days. If there's no gauze, it's
Every 48 hours.
every 48 hours. Y'all need to go back and look at that. IV piggyback. As an LPN, can you hang an IV piggyback at the same level as the primary bag?
No.
No. It has to be higher.
It has to be higher. What has to be higher? The primary?
piggyback.
Back has to be higher than the primary. Yes. All right. What do we use in order to prevent infections other than hand washing and other than ChloraPrep?
Non-chlor.
Say it again.
Chlorhexidine and 70% alcohol.
Okay, what else?
Betadine.
Biopatch, or you can use betadine or providone iodine if the person is allergic to ChloraPrep. What else do we? Stabilization devices. Yes, absolutely. All right. Taking care of a patient that has tuberculosis. What lab value are you going to monitor for rifampin? Platelets. The platelets. Yes. You have a patient and you're doing a CVC.
Can you?
What med is that? For rifampin. Platelets. You have a CVC dressing that you need to change. Are you going to wear a mask when cleansing the CVC insertion site?
Yes.
Are you going to apply the BioPatch blue to the body?
No.
To the sky.
To the sky? Yes. Are you going to cleanse the CVC site with chlorhexidine over the insertion site for at least 5 seconds?
No.
No. Again, y'all need to go back and look at the CVC dressing cane. I'm not sure. I get the feeling that y'all are not real clear on this. I might be wrong, but go back and look at that, please. All right, the RN is going to delegate to you to start and discontinue a peripheral IV in the forearm of a 13-year-old. Can you do that?
Yes.
Yes. Can you hang Zantac, IV piggyback?
No.
No. Can you hang the first bag of normal saline with an ampule of multivitamins in it?
Yes.
No.
First bag, no. No. All right. Can you initiate the first bag of normal saline with 40 MEQs of potassium in a 60-year-old?
No.
No. Can you hang an IV piggyback on a 75-year-old?
Yes. Yes.
Yes. Can you hang lactated ringers on a 16-year-old?
No.
No. Can you hang Zantac on a 40-year-old?
No.
No.
All right. You have a patient that pulled out their IV. What are you going to do?
Assess the site and put it in a different area.
That's right. Assess the site and put it in a different area. Now you got a 30-year-old patient whose blood sugar is 500 and they're positive for ketones. What order would you question? Normal saline, an insulin drip, normal saline with potassium, or D5 normal saline?
D5.
It's the D5 normal saline. Yep, the D5. All right. You're working and you have six patients that we'll do. You got three patients you got to take care of. You have one that's recovering from pneumonia. Now their respiratory rate is up to 50, and their O2 sats are 60. You have another one that's a diabetic with the saline lock, and their hemoglobin is 9. You got another one that has a hip replacement that didn't sleep well, and they got an IV that's infusing normal saline at 75 mLs per hour. Who you gonna go take care of first?
First
The
one.
first one.
First one, yep. Central bundle line. This is another one y'all struggled with if you were with me yesterday. What exactly is the central bundle line, and why do we use it? Central line bundle.
Is that like an evidence-based,
Okay.
something for the doctor, evidence-based, for the doctor to use to keep the stroke technique or something like that?
No, not for the doctor. Is
Well,
it for
the
the
kid.
doctor?
The moral, I know that much.
Like, wash his hands first.
Yeah, it's like the kid for the wash their hands, the sterile gown, the gloves.
Okay. And the cap,
Yeah.
and the drape. Okay. So povidone iodine is the preferred skin antiseptic.
It's chlorhexidine, ain't it?
It's chlorhexidine. Yes, the femoral site is a good spot to go into. False. A full maximum sterile barrier will be used when a
Yes.
CVC is inserted. A full maximum sterile barrier.
Yes.
Yes. Nurses will review the CVC line until it's still needed.
Yes.
Yes.
That's true. I still want y'all to go back and look at the central line bundle.
That consider like the national safety precautions?
Hello.
Or...
Yes. It's not for doctors. It's for who?
For the nurses.
Y'all.
Okay.
Yeah, it's for y'all. Okay. All right. You're a nurse and you're taking care of a patient that has access to, well, the patient taking care of patients with IV accesses. The patient with the PICC line has a CVC dressing with the corner that's loose. Another one has a peripheral IV. The site is slightly red and to touch. Another one, the peripheral IV site, has a red streak, thick yellow drainage. Which one you going to first?
The last one.
So this last one, this peripheral IV, has a red streak and thick yellow drainage. What is that?
Phlebitis.
What is it?
Is
Well,
it
yeah,
the one that we
that's
agreed
That's
for?
grade 4.
Oh, okay. I was just checking. So, what's the difference between 3 and 4?
Grade 4 has the drainage.
Grade 4 has the drainage. Yes. All right. You have patient that you want to consider is appropriate for infusion of a catheter. What do you take into consideration when you're trying to determine the appropriateness for the infusion of a catheter for a patient? As far as infusion.
The condition of their vein, the solution used,
Yes. What else?
Length of the time that the catheter is needed.
Yes, the length of the time that the catheter is needed, the patient's conditions of their vein, and the type of solution that the physician orders. That's correct. All right, standard practice for administration sets. What are they? We just went over these.
sterile technique,
Yeah, what else? For administration sets, standards of practice for administration sets. Remember,
Change them every 96 hours.
if what? What's every 96? You're right, but what's every 96?
changing primary,
Change.
Primary. Okay. Then what? What else has to do with administration sets? The standards of practice pertaining to administration sets.
Change immediately upon.
oh, using the alcohol caps.
Okay, what else? What did you say, Celine?
It's Venetia actually.
Oh, sorry. You sound like Celine.
Change immediately upon contamination.
Yes, absolutely. What else?
Piggyback change once every 24 hours.
Yes, the intermittent has to be changed every 24 hours. For some reason or another, I think y'all are caught up on the administration set. And all we're talking about is the tubing. That's it. talking about the tubing, the standard of practice for changing tubing. All right, Celine, are you on here?
Yes, I'm here.
Okay, y'all sound
Yeah.
just alike. All right, prevent vascular access infections. How do you go about doing that? Preventing vascular access. Sterile technique. What else?
Tubing and the solution expiration date.
Yes, the tubing and the expirate. Is that Jasmine?
No, Debrica Sims, Westchester.
Girl, you sound like Jasmine. Yes.
All right, Madonna, just leave it alone.
You want to check the expiration dates on tubing and IV fluid. Y'all don't show your face, so I don't know. Removing the peripheral line if there's redness or as redness is noted. And then what about the spike?
Sterile spike.
Keep the spike sterile. You can't touch it with your fingers. Don't get caught up on. Go ahead, say it again.
And allow the antiseptic to dry.
Yes,
Of course.
absolutely. Yes. Don't fan it. Don't blow on it. All right. Local complications. What are they?
Infiltration.
Yeah. What else?
Hematoma,
Spasm. Spasm.
constipation,
Listen.
Hematoma.
Local complications are infiltration, extravasation, phlebitis, and hematomas. Those are the local complications. Infiltration, exacerbation, phlebitis, and hematoma. All right.
Dawn, I'm sorry. So venous spasms is not there, right?
No,
Okay.
it's not a local complication. Local complication. Venous
But
spasm.
local
What
means-
exactly is this venous spasm? What happens? What's going on with that?
So I just wanted to confirm a local complication is something that happens directly at the site.
That's correct. But I'm asking a question about venous spasm now. What's going on with venous spasm? How does
Venous
that occur?
spasming. Actual
so-
venous spasming.
Yes, it is. So how does that occur though?
Is that when like the fluid is getting into the vein too fast or something like that?
So when you infuse cold solutions,
It's when you infuse a cold solution.
Oh, cold solution?
Yes. All right, now, healthcare acquired infections, are they life-threatening?
Yes.
Are healthcare institutions reimbursed when they receive them in the healthcare?
No.
No. Is it a national patient safety goal concerning infection prevention?
Yes.
Yes. So how do you prevent infiltration and exacerbations? How are we going to prevent that from happening?
Allow the solution to come to room temperature.
Yep, what else?
do not attempt peripheral IV more than 2 times.
That's right. As a nurse, you should never attempt to do an IV no more than 2 times. All right, what else?
don't place it over the joint.
Yep, don't place it over a joint. What else?
Check every 2 hours, something like that. Check location.
Yeah, check the IV site every 2 to 4 hours. That's correct. It's usually 2 for children and every 4 for adults. Unless it's a vesicant, you might want to check a little more. And then you also want to make sure that you've educated the patient on what they need to report and what do you want them to report to you.
Redness and what?
Yeah,
And pain at the site. At the
and
IV
pain.
site.
Pain, burning, or swelling at the IV site is what you want to teach them. All right, septicemia. What are the signs and symptoms?
Low blood pressure, low
Yeah.
white blood count, elevated temperature, redness,
Yeah.
low
Sweating.
heart rate, and
heart rate.
profuse sweating.
And profuse sweating. Okay, what else?
Isn't it high WBC?
Oh,
The
vigorous
Elevated
Vigorous
WBCs,
chills.
elevated lactated ringer.
Yeah, elevated WBCs, elevated lactated ringers, vigorous chills, and the patient becomes restless. I would go back over that if I were you all.
Tachycardia, tachypnea.
Yep, tachycardia, tachypnea. Yep, absolutely.
Ataxia.
Hey, huh? Say
Hypo-
it again. I couldn't hear you. I have a crazy look. Look, I just look crazy.
Hypoxia.
Hypoxia is that part of septicemia?
Yes.
Yes. Okay. All
Was
right,
it
you have
low heart rate or high heart rate?
hypotension,
That's blood
tachycardia.
Okay.
Okay, now, bloodstream infections. That's in your workbook, y'all. The septicemia, but I don't know what page.
I always just remember with an infection, your heart is beating faster, trying to fight that infection, your respirations are going faster, your body's just trying to fight that infection. So it's going to be elevated.
Yep. All right, bloodstream infection. How do you prevent it? Could you prevent it by, could you contribute to it by cleansing the tubing with alcohol for 30 seconds after it touches the floor?
No.
That would not contribute to infection?
It would contribute. You need
It would contribute, yeah. If the nurse places the PICC line dressing with the sterile glove for INS standards, would that contribute to infection?
No.
No. That's how you want it to. That helps to prevent infection. If the nurse fans on the chloroprep,
That contributes to
that
infection.
contributes to the infection. That's what I'm asking you for. What would contribute to it?
Not allowing it to dry.
Yeah, and also fanning it. If the nurse is using a 4-way stopcock with the IV, when she removes the tubing, she leaves the port uncapped.
Yes.
Yeah.
Yes, that is going to contribute to the infection. Yes. All right. Jugular vein distension, 2 kilogram weight gain in 24 hours, and edema all over their body. What are you going to do? Yeah. Well, what you going to do about it?
Stop the infusion.
So I didn't say they had an IV.
So we're gonna elevate the head of the bed.
Okay. What else you going to do?
There's furosemide.
Can you
got
give
order
it?
for a Lasix?
Okay, wait, stop. Can you give Lasix IV push?
No.
No. You're gonna elevate the head of the bed. You may get an order for Lasix. Now, what else are you gonna do?
Give off
Their eyes and nose.
The eyes and nose. What else did you do?
Wait.
restrict the fluid.
The weight. You might have to restrict the fluids. Anything else you want to do for this patient?
Elevate the oxygen, maybe.
Give them some oxygen. So we want to do weights, eyes and nose, restrict the fluids, give them some oxygen. You might get an order for Lasix. And then you might want to go ahead and start a peripheral IV and attach a saline lock because they may end up needing some fluid. All right, sterile technique. Would it be you set up the sterile field 60 minutes ahead of time?
No.
No. Can you turn your back on your sterile field? No. Can you put your hands below your waist?
No.
No. Can you go ahead and rub your nose and throw your hair back? Pull
No.
up the sleeve with your sterile gloves?
No.
No, you cannot. All right, you got a patient that's 90. They got a history of CHF, and they recently underwent a hip fracture and a repair. Are they at risk for phlebitis?
Yes.
Why?
Because they are elderly and have fragile veins.
Yep, they are elderly and they have fragile veins, which increases their risk for phlebitis. Yep. All right, now, let's see. You got a 50-year-old patient that has pneumonia. They're short of breath and they have a respiratory rate of 33. Their O2 sats are 89. Their pH is 7.15. Their CO2 is 50. Their HCO3 is 29 and their O2 sats are 65. What would you anticipate doing for this patient?
Oxygen, raise the head of the bed.
Yeah, what else? Oops. What else would you do for him?
Raise the head of the bed.
Okay, raise the head of the bed, give him some oxygen. Anything else?
Can you say their stats one more time?
Ooh, girl, I make them up. The pH is 7.15. The CO2 is 50. The HCO3 is 29, and the O2 sats are 65. The pulse ox is 89, and the respiratory rate is 33. What about a nebulizer treatment? because they're short of breath. That respiratory rate of 33. What about a nebulizer treatment? And there is a possibility that we need to start a broadband antibiotic and then wait for a culture to come back because it might be pneumonia. You think?
Maybe.
I thought you said that the patient already had pneumonia.
Probably did. And like I told you, I make this stuff up and I probably didn't say it on the second one.
Okay.
All right. You got a UAP that you're delegating to. Can they get your vital signs for an unstable patient? No.
No.
Can they apply non-prescription cream?
Yes.
Yeah. Can they notify you if the IV pump keeps beeping?
Yes.
Yes. You have a patient that has nausea, vomiting, and diarrhea. They got a heart rate of 92 and they got a blood pressure of 80/40. What would you anticipate doing for this patient?
Stool specimen.
A stool specimen. What else are you going to do?
Check BB every 30 minutes.
What else?
Give rectal suppositories or nausea and vomiting.
That's right. Yep.
Encourage fluids.
And then, yes, if you can get them to drink the fluids because of the nausea and vomiting. So what fluid would we give to this person? Nausea and vomiting.
Electrolytes. Gatorade.
Electrolytes. Gatorade. What kind of fluid though?
Normal saline.
Normal saline would be good. Okay. All right, you got a patient that has streaks on their arm from the IV site. It's a palpable cord in the vein. What grade is that?
4.
Grade 3.
Three.
There's no
It doesn't have any
drainage.
pus. Exactly. A grade 4 has the pus. What kind of needle do you use for an implantable port?
Non-coring.
Non-coring. What labs are you going to monitor for Zithromax? White blood count, right? Because it's an antibiotic. We want to know if it's working. You got a 50-year-old patient that has sepsis. What interventions are you going to put in place?
Antibiotics.
Antibiotics, yes. What else? Huh?
Catheter.
A catheter? Yeah. What else?
Monitor their blood pressure.
What else?
They go to a higher level of care. No.
That's a possibility. We did say that. That's what it says in the
Spectrum
workbook.
antibiotic.
So we want to give them an antibiotic. We probably are going to have to start an IV, right? Because they're probably going to need an IV antibiotic. And we also probably are going to give them some fluid. What fluid do you anticipate us giving them?
I know you made it up. I'm
Normal
sorry.
saline. Normal saline. That's the fluid. Yep, absolutely. And then also we want to make sure we have that Foley catheter. Somebody already said that, but we got to make sure we got the catheter in place. Why do we want a catheter for a person with sepsis?
They might experience retention, urinary retention.
Right, but also because we know that they usually have a low urine output with the sepsis, so we got to monitor. We got to make sure what's going in is coming out too, right? Yes.
Yeah.
Are y'all still with me? All right. You got a patient that has speed shock. Would they have a mild headache?
Pounding
headache.
Severe headache. Yeah. Her blood pressure would be low.
Low blood pressure.
Yes.
Elevated heart rate.
Yeah, go ahead. That's right. All right. Now you got a hematoma. What's the definition of that?
Blood in the vein. Blood under the skin.
Blood under the skin. Nothing but a bruise, right? Venous spasm. Caused by what?
Solutions or refusing to enact.
Venous spasms are caused by cold solutions. I heard two different things and I wasn't sure what I heard. That's why I hesitated. Infiltration.
Asking what it's caused by.
Yeah.
That's like when the fluids get into the tissues.
Okay.
And
how
it's
do-
not a vesicant.
as long as it's not a vesicant, yes. And if it is a vesicant, what is it?
Exacerbation.
Exacerbation.
Yeah.
I'm glad I didn't ask y'all to spell that one. I'm joking. It's
Right.
a joke. Grade 4 phlebitis. The fluid leaks into the tissue. Is that true?
No.
No. What's happening with the grade 4 phlebitis?
Coming out.
Coming out.
Bus.
Pain,
Say it.
edema, street formation, palpable venous cord, and purulent drainage.
Okay. Can it lead to an amputation?
Yes.
Yes.
Yes. Yes, it can. What is the correct treatment for phlebitis? The correct treatment for phlebitis.
Elevate the extremities.
Warm compress.
I
Well,
think it's cold.
It's warm.
okay.
You have to determine the cause.
You got to determine the cause first. Determine the cause first. This is in your study guide on page 37. I would go back and review that. Okay. What's your first line of defense
Elevate the extremities.
for infection?
Skin.
Skin. All right. Sepsis. Go back and review it. Make sure you know your blood gases. Also, what else? What else did we go over? Macro drip. Make sure that you have a true understanding now as to how to set up those mouth problems if it's asking for macro drip. Make
And
sure
what
you
is
have-
macro drip again? Micro is 60, right?
Micro is 60, y'all?
Yes.
Micro is
Micro.
micro is 10.
Macro
Yeah, macro is
Oh my God.
Wait, stop.
Micro, yes, micro is 60. MICRO is 60.
macro.
Macro is
Macro is 10 to 20,
20.
micro is 60. So look, here's what I want you to do. All of y'all need to go back and look at your workbook and determine. What you making, Brandon?
I know, I'm missing it like, it looks like whatever he get into it.
I'm making homemade, pasta sauce and
Oh my God, it's huge.
I'm coming over. I'm sorry.
Oh, I don't know where you live, but it looks like you got enough for all of us. Macro and micro drip, y'all need to go back and review that. Y'all need to go back and review your sepsis and make sure that you have a true understanding of concentration and the other thing, what was the other thing that everybody was gonna uproar about and wanted to argue about? And it's plain as day in your workbook, but I can't think of what it was now.
We were
Oh,
talking about the CBC.
The CBC dressing, thank you. That's the one. When do you change it? It's based on when you have a gauze and when you don't have a gauze. So go back and review that so you have a true understanding of that. And then, what else? That means if you have to go back and read it 60 times, go back and read it 60 times so that you have a true understanding. What else? There was something else that came up. I don't know. I can't remember. Y'all know what it was. What was it?
Another thing with the CBC about how long to clean.
Yes. How long do you cleanse the area when you're doing a central line dressing change? A central
30
venous
seconds.
catheter. Yes, it is 30 seconds. That's in your workbook as well. All right. Those are the main things. The sepsis still seems to be a struggle, and I'm not sure what's going on there. So go back and make sure you have a true understanding of sepsis. What you're going to do about it, what the signs and symptoms are, and then some of you are struggling with the grade 3 and grade 4 phlebitis. Go back and make sure you have a true understanding of that. And then venous spasm is because of cold solutions. Make sure you understand that. Know the definition of hematoma. I think that was it. I think those are the main things that I saw, that I picked up on that people were struggling with. Anybody have any questions?
So if they tell us the drop factors for macro tubing, do we do 10 or 20 drops?
So I doubt very seriously that you're going to have a problem that just leaves you out there like that. If it does say that, it will be specific in saying that the tubing is 10 drops per ml.
Okay.
So here's the thing that you have to do with these mouth problems. All it is telling you a great big story. You have to determine what part of that story you need. That's all it is. It's a story problem. You remember when you were in, well, maybe y'all didn't have it. when you were in elementary school and they gave you math problems. That was like a story problem that you had to figure out. How fast is the train going? If it's going 80 miles an hour, 60 miles away. Y'all are like dead silent. I would love to see your faces because obviously you didn't have anything like that in school. Is that correct?
I did.
I did.
You did? Okay, I was just checking because it was like dead silent. That's
Not
all.
at DPS.
Huh?
Not at DPS.
Not in GPS.
DPS.
What's DPS?
Detroit Public Schools.
Oh, girl, I'm sorry. I'm so sorry. But anywho, that's all these math problems are. It's got a whole bunch of hoopla in there, but you have to pick out what you need for the math problem. Now, in reality, you need all that information when you're actually hanging the ID. But when you're trying to figure out the math problems, what do you need? You need the mLs per hour. You need the tubing. You need to know how long, and you need to know what you're trying to figure out. mLs per hour, drops per minute. Make sense?
Makes sense.
Okay. Take control of the math problems. Don't let them run you over. And stop being intimidated by them. That's the other thing. You can do this. I believe in you, but you got to believe in yourself. All right, y'all. I'm out.
Thank you.
You're welcome.
Thank you.
Thank you.
Thank you.
Bye.